And so we came up with this idea to replace Kodachromes with digital images and search, and to create a real-time decision support system. And the idea came from doing dermatology in a small town in western New York called Batavia, New York, where I was the only dermatologist for about 70,000 people. And what I noticed was that most of the primary care docs could not diagnose even the simplest things. Like they were missing herpes simplex, they were missing very, very common things. So I got very interested in this area of diagnostic error. And that's really the problem we're working to solve at VisualDx. And anyone hear about this report from the now called the National Academy of Sciences Institute of Medicine 2 years ago on diagnostic errors and diagnostic failure? Everybody's heard of To Err is Human, I'm sure, in 1999. This report came out 2 years ago, and they said that nearly every person will experience a diagnostic error in their lifetime. So that means myself and everybody in the room will probably experience a diagnostic error. And so we created this infographic to kind of highlight what the media is concerned about is wrong site surgery, ends up in the news. The wrong leg or kidney comes out, it's in the media right away. But when you go to your doctor and they say, try this, and you come back and then you're given a different prescription and it doesn't get solved and that goes on for a while, that happens a lot more frequently than wrong site surgery or some of the other issues that were highlighted in the 1999 To Err is Human. So we also created this infographic to kind of make it more palpable. So you have a ER physician, say, seeing 20 patients in a shift or a day. 2 of those patients are probably going to be diagnosed incorrectly. And so one of these, we actually use an experience from our office. We had some employees with headache. And here it says, diagnosed tension headache, did not realize workplace exposure to carbon monoxide. Our prior offices were connected to a warehouse, and the air circulation from the warehouse was coming into our office where there was carbon monoxide from the propane forklifts. And employees had headaches, so it really tied to Dr. Weed. It's like that physician would have had to say to the patient who came with a headache, where do you work? What could you be exposed to? And it really highlights this idea of patients come in with problems and you need to know the questions to ask. And so this problem of diagnostic error where we rely on cognition is a huge problem in healthcare that is yet to be addressed. So how many here in the room are part of a healthcare system? Okay, how many of you would say that your system is working to improve diagnostic accuracy in a formidable way? Have you ever evaluated tools to improve diagnostic accuracy? The answer is usually no. But when we start to think about ACOs and capitated payment structures, you really begin to realize that churning patients is a bad thing for the ACO. Getting the diagnosis right first is going to financially become a necessity. It's also going to help you with MIPS and MACRA. We touched that earlier. So a little bit about VisualDx. So we've been around a long time. We were founded in 1999. We argue this is the first diagnostic support system to actually get used. So the history of diagnostic support goes back 40 or 50 years. So we're in about 2,300 hospitals and large clinics using VisualDx, and over 90 medical schools are teaching with it. And when we go in, we talk to the CMIOs and the CIOs and the CMOs about the efficiency gains from the system. So we're not just talking about diagnostic error, we're talking about how our tool helps in other ways in medicine, not just diagnosis. So it's used by MDs, NPs, and PAs, and the sweet spot is emergency medicine, primary care, and some of the specialists, including dermatologists, infectious disease, and rheumatology. So it's used widely, and it's used on the iPhone, the Droid, and the desktop. So one of the things I want to highlight is the shift that we're living through, and I think it probably impacts many of the companies that are starting. I mean, we're living through this transition from when I was in medical school where you had these things called books, and you read them, and you try to memorize the books, and you take your boards, and they were unaided decisions in the clinic, and you had someone with a white coat who was questioning you, and you had to do it all out of your brain. Today, when I'm with my residents, I'm encouraging them to use these apps. I want them to grab evidence to solve the patient's problem, because when they end up in practice, I want them to grab evidence to solve problems. So I really believe in like an open book way of teaching. And I think we're going to see that transition over the next few years, where this generation who's much more comfortable with smartphones is going to be using these tools in their pocket. So another part of our story is thinking about visualization of information. And so doctors have about a minute to do their thinking in a typical exam room. And so if you give a doctor an online book, it's very, very hard to read with the patient sitting there. So though we started with pictures of dermatology, we eventually grew to this idea of the sympticon, or symptom icon. And so what we've done is we've created these diagrams to show the key features of different diseases, and I'll show you that in a minute. All right, so the connection here at this meeting is VisualDx and FHIR. We have a wonderful Chief Technology Officer, Roy Robinson, who at AMIA about 5 years ago or so learned about SMART and FHIR and came back and said to me, we really need to be working with this thing called FHIR. And I didn't know anything about FHIR, and I don't personally write a line of code, but Roy is good. I said, okay, let's do it. And we worked with Cerner probably 3-4 years ago on a prototype, and was the first commercial app in the Cerner Code App Store. And what we're doing is we're grabbing the patient age, the gender, the problem list, and the med list to launch VisualDx and contextualize the search inside of Cerner. So we're trying to provide the user with a richer experience so that the imagery fits the patient age, the patient gender, and their problem list and their med list. So this is how it looks, and I think I'm going to be able to get into demoing it live, but not inside the Cerner frame. And what's new is I presented at the Boston meeting is we've now created an interface where we can show the timeline of when a med was started and when it was stopped. And so this is really important when you're with a patient that's on multiple meds and you have the suspicion of a medication-induced disease or a drug reaction. So I remember when I did the consult service at our hospital, a frequent request is in the bone marrow transplant unit, is this graft versus host disease? Is this a drug reaction? And the patient's on about 25 medications. And so you want to have a sense of when did each med start? When did it stop? What's the relationship between the start of a medication and symptoms developing? So we felt that if we took, before what we had was just the med list, that we graphically represented start and stop dates, that would be helpful in choosing the right medications to investigate with our app. So you can check adverse medication reactions, or you can research diagnoses from the problem list. And how much time do I have? Some sense to that? About 5 minutes. Wrong one. So here's a list of medications in a patient chart, and you could say, and I'm sorry that it's not really displaying a timeline that says that mesalamine has been started recently. The demo site doesn't have the timing for the demo, but imagine that mesalamine was recently started and I was curious about that. I'd click that and it would set up a workup for that, and I could enter any of the other symptoms that might be relevant. So say the patient was having chest pain, I thought I wanted to check that, and the patient recently developed shortness of breath. Then I hit to view the differential, and it would give me those sympticons. I'll make them larger so that you can see them. And it has drug-induced lupus, pericardial infusion, and respiratory failure, and pericarditis. And you might say, well, what's the evidence? How do we know that mesalamine can induce these diseases? And you'll see a little pill with a number next to it. And so what we've been doing for over a decade, we have 4 or 5 full-time librarians, and we literally sieve PubMed looking for case reports of drug-induced disease. So here's the evidence that mesalamine can induce lupus. And here's the evidence that it can do pericardial infusion. There's 7 case reports of pericarditis. So we're using the number of case reports of a medication to disease relationship as a proxy for frequency. Now it's a suboptimal proxy, but it's better than typically what you find in Hippocrates or Micromedics or Lexicomp, because what those resources are doing, they're using the original drug trial study adverse events, and you'll see it'll say headache, nausea, vomiting, and you'll just get a laundry list. So what we're doing here is we're saying we can show you the matches of the drug with any findings that you entered. Now, obviously, what we want to start doing with FHIR is to start to pull more data from the record. Like we could start to pull lab information, we can start to pull other past medical history information to make for a richer differential. So I'm going to go back to the front of VisualDx and show you that VisualDx has multiple different fields that can be searched to build a differential. So if I said a patient had traveled to Haiti, we could go in and say the patient went to Haiti and there were blanching macules. Which infectious diseases that are endemic in Haiti have blanching macules? And you say, oh, I never heard of chikungunya. What does that look like? And then we can show you the features of chikungunya, and then you could view it larger images. And if you didn't know what chikungunya was, you can jump over to the synopsis and read about tests for chikungunya. So what really makes VisualDx different is the ability to search multiple patient variables, build a differential, and then visualize the results. And in homage to Larry Weed, what we're working on now is what we call guided chief complaints. So the idea is, Larry had said 30, 40 years ago, well, the problem is you can't remember the questions to ask. So if you took a kind of a less frequent chief complaint like diplopia, the system will say workup for diplopia, and will remind you to check to see if it's binocular or monocular. Is it persistent or is it intermittent? What are the other symptoms that are relevant to the workup of diplopia? So we could say there's nausea. And what are the eye symptoms that you should be asking your patient? Do they have eye pain, blurred vision, photophobia? So you can sense that you can be predictive and start to, around a chief complaint, guide the workup. And then the next step is to think about how you can move that into the home. A patient has symptoms, and you start asking them on their iPhone about their symptoms before they get to their visit. So as another example of guided workup here, if I go to lip rash, it will say workup for lips, and it says onset. It developed acutely. What type of lesion? They're scaly. What lip exposures have you had? So it says lanolin-containing skincare products, neomycin cosmetics, and mango exposure. So we would not, as dermatologists, expect primary care to know to ask about mangoes, because mangoes cross-react with poison ivy, and if you react to poison ivy, you eat a mango, you're going to have a lip rash. So this is background on the idea of being predictive about the questions to ask. And I see the sign there, and I thank you for your time and attention. Thank you.